Welcome to everyone to our conference on two-tier care, the future, private finance in Canadian Medicare. Je m'appelle Colleen Flood et je suis la directrice du Centre de droit politique éthique de la santé. My name's Colleen Flood. I'm the director of the Centre for Health Law, Policy and Ethics here at the University of Ottawa. I'm currently also the Associate Vice President Research for the university. This conference will be in English, but all of our moderators are bilingual, so if you wish to ask a question en français, please feel free to do so. So we're going to kick off our conference with this free public lecture. The rest of the conference will be tomorrow in Desmarais, and for those of you who didn't read the program, room 4101. In Desmarais in the Telfer School of Management. So our subject today is two-tier healthcare in Canada. And as most of you know, there is a constitutional challenge that is ongoing in BC, brought by Canby Surgeries Corporation, a private clinic that is challenging BC laws that restrict two-tier healthcare. This was in the news yesterday. Some of you may have seen it in the Globe and Mail, where BC imposed stiffer penalties for those clinics and physicians who extra bill, contrary to BC law and to the, arguably at least, to the Canada Health Act. Now, so our goal with this conference is to understand the broader implications of this challenge and what this means for the future of public Medicare. And in particular, we want to come to grips with what would happen if a court should rule that one or more of the laws currently protecting public Medicare are unconstitutional, and how should provincial and federal governments respond if that does occur. So what policy options would governments have if there was such a ruling? And to this end, we have experts, as you'll see tomorrow, from France, from Australia, and from Ireland, who are going to help us understand how two-tier care functions in those systems. And then we have experts from across Canada who will be reflecting on how we should think about that from the perspective of the Canadian system, and what issues or problems might we have in thinking about trying to adapt any of those systems to our particular context. So without further ado, we're going to start this panel, and I'm going to ask Dean Adam Dodek, who is from the Dean of our law school here, to come up to introduce the moderator for this panel. So Adam, please.
Thank you, Colleen. Au nom de la Faculté de droit de l'Université d'Ottawa, je vous souhaite la bienvenue à cette conférence. Je voudrais reconnaître que nous nous trouvons ici sur un territoire algonquin non cédé. I want to recognize that we are holding this conference here at the University of Ottawa on unceded Algonquin territory. And this recognition is important, especially when we're at a conference that is talking about, is two-tier healthcare the future? Because certainly for the Indigenous peoples of this country, two-tier healthcare has been a reality for many years. And at the Centre for Health Law, Policy and Ethics, which Colleen directs, certainly Indigenous health has been an important focus, with the Associate Director, Yvonne Boyer, who is now Senator Yvonne Boyer, who has been named to the Senate and joined the Senate just a few weeks ago. And Indigenous health will continue to be a focus at the center. At the faculty, since I've been dean for all of 3 months, I've started to, you see things differently when you look through different eyes, hold different positions. And what I've come to realize is some of the themes that characterize our faculty are very much excellence, leadership, and community. And when I think about this center, the Center for Health Law Policy and Ethics, those three themes really, really shine out. You think about all of the people that are involved in the center. You look at the people that they have brought together, that you will hear from over the course of the next 2 days. And they are not only established people who have excelled in their fields, but they are absolute leaders in their field. So excellence and leadership and community, what we are talking about, this is a community lecture. This is open to the community. What the work that the center does is very much engaged with the community. So for me, the work that this center does very much exemplifies the best of what we have to offer here at the Faculty of Law and the best of what we aspire to be. So thank you very much to all of those involved in the center, to the leadership of Professor Colleen Flood, and to all of you for coming here today. It's my pleasure to introduce the moderator for the first panel, Dr. Robyn Tamblyn. Dr. Tamblyn is professor in the Department of Medicine and the Department of Epidemiology and Biostatistics at McGill University. She is the James McGill Chair, a medical scientist at the McGill University Health Center Research Institute, and the Scientific Director of the Clinical and Health Informatics Research Group at McGill University. Her groundbreaking research on educational outcomes has elucidated important relationships between health professional training, licensure, and practice that has subsequently guided credentialing policies. Her work on prescription drug use, its determinants, and computerized interventions to improve drug safety have been recognized internationally. She leads a CIHR-funded team to investigate the use of e-health technologies to support integrated care for chronic disease and co-leads a Canadian Foundation for Innovation Informatics lab to create advanced technologies to monitor adverse events in populations and create new tools to improve the safety and effectiveness of healthcare. As of January 2011, she became the scientific director at the Institute of Health Services and Policy Research at the CIHR. She was appointed to the Order of Canada in December 2014, and let me congratulate her on recently being named the 2018 Emmett Hall Laureate. The Emmett Hall Laureate is one of Canada's most prestigious lectureships. It commemorates the father of Canadian Medicare with an annual address at the CIH-SPR conference. Each year, the laureate is awarded on the basis of outstanding contributions to the health ideals articulated by Justice Hall: equity, fairness, justice, and efficiency. It seems that we could not have chosen a better person to kick off this evening's panel than Dr. Henry. Thank you.
Sorry, well, that was a bit embarrassing, actually, so thank you very much for that lovely introduction. So welcome, everyone, and to this public lecture. Just want to take this moment to thank Colleen, who is a very special leader in Canada. I presume now an honorary citizen of Canada. She has always taken the really hot topics that we all talk about and worry about secretly, and she brings them into these public forums for debate, discussion, and sort of international insight. So thank you again, Colleen, for today. It's my privilege to introduce this first kickoff panel. It's going to be a fantastic afternoon/early evening. Just a little housekeeping, phones off. You know, there's a little button on your phone that says, turns off the ringer thing. If you can't find it, your seatmate will help you. Number 2, no smoking, cigarettes, that is. Number 3, washrooms and so on are out the door to the right and down the hallway. And if you have any other questions, please come see me at the break. So our panel is going to present, and I'm going to introduce each of them individually as they're about to speak. They'll be speaking for 15 minutes. We're going to hold questions to the end. We have a great half hour of questions and answers with mics here and there. Please take a pen and pencil, write down your questions as they evolve, and we're going to get the show on the road. So let me just get going. So our first speaker is Dr. Martha Jackman. She's here at the Center for Health Law Policy and Ethics. She's a professor of constitutional law at the Faculty of Law, University of Ottawa, where she has taught in the French Common Law program since 1988. Her area of interest includes socioeconomic rights, federalism, the Canadian Charter, and health. She's acted as the legal counsel on a number of charter test cases, including the Supreme Court of Canada in the Eldridge versus British Columbia, 1997, and Chioli versus Quebec in 2005. Thank you very, very much, Dr. Jackman, for being our first kickoff presenter.
Thanks very much. I hasten to add that I'm not a doctor, and I can prove it because I just glugged back a bottle of over-the-counter cough medicine, which I'm sure is completely ineffective, to prevent myself from having a coughing fit. I've got this plague that's gone around Ottawa this year. It's been pretty amazing. So thanks very much to the Centre for the invitation. It's really a pleasure to be here amongst kindred spirits. Unlike the Universal Declaration, the International Covenant on Economic, Social, and Cultural Rights, which Canada ratified in 1977, and many other 20th century constitutions across the world, the Canadian Charter of Rights and Freedoms, which was enacted in 1982, does not contain a freestanding right to health or to health care. Instead, Section 7 of the Canadian Charter guarantees everyone in Canada the right to life, liberty, and security of the person, and the right not to be deprived thereof except in accordance with the principles of fundamental justice. And it is on this Section 7 guarantee that Dr. Brian Day is relying in his Cambie Surgery's challenge to the single-payer healthcare system in British Columbia. Specifically, Dr. Day is invoking Section 7 of the Charter to challenge all the underlying provisions of the BC hospital and health insurance system. The prohibition on extra billing by physicians and on user charges, the prohibition on duplicative private insurance, so private insurance for services that are funded under the public health insurance system, and a physician dual practice, which we commonly call double dipping, as well as fee caps for non-enrolled physicians delivering delivering services in publicly funded hospitals and clinics. So the Cambie Surgery's challenge actually emerged as a response by Dr. Day to allegations that he had been involved in illegal billing practices, he and a number of colleagues running private facilities in Vancouver. And in fact, a 2012 audit by the BC Ministry of Health found that in less than a single month in 2012, the Cambie clinics or associated clinics had engaged in over $500,000 of illegal billing and $66,000 worth of billing that looked like double billing. So in response to this challenge of illegal billing, Dr. Day argued that any restrictions in the BC health and hospital insurance system that were designed to protect the single-payer system violated Section 7 of the Charter and had to be struck down. In advancing this argument, Dr. Day relied on the 2005 Supreme Court of Canada decision in Chioli. And as was mentioned, I'm far from indifferent as to that case. I represented the Charter Committee on Poverty Issues and the Canadian Health Coalition in their intervention in that case. In the Chioli case, Monsieur Zeliotis, who was an elderly gentleman who'd had experienced delays obtaining 2 hip replacement surgeries, and Dr. Jacques Chioli, who was a physician who had immigrated to Quebec from France and was involved in a long-running battle with the Quebec government in his efforts to deliver private care. So Monsieur Zeliotis and Dr. Chioli argued that Quebec's ban on private health insurance violated Section 7 of the Canadian Charter, as well as the equivalent provision of the Quebec Charter of Rights and Freedoms, Section 1, which protects personal inviolability. At trial, Justice Pichet found that indeed, in some cases, wait times might well infringe life and security of the person of patients waiting for critical care. However, she went on to conclude that the ban on private insurance in Quebec did not violate Section 7 because it was in accordance with the principles of fundamental justice. Justice Pichet found that the ban on private insurance was to ensure that all had access to care based on need, not simply those who could afford or who were eligible for private insurance. Justice Pichet further found that the ban on private insurance was consistent with Section 15 Canadian Charter equality guarantees of equal protection and equal benefit of the law without discrimination, and she found that even if the ban on private insurance had been found to violate Section 7, it was justified as a reasonable limit on charter rights under Section 1 of the Charter. And the Quebec Court of Appeal agreed with Justice Pichet. However, in a surprising 4-3 split decision, the Supreme Court of Canada overturned the trial and appellate decisions and granted Dr. Shaoli's claim. Dr. Deschamps held that the insurance ban violated Section 1 of the Quebec Charter. And she stated fairly notoriously that governments have lost sight of the urgency of taking concrete action on wait times. The courts are therefore the last line of defense for citizens. Chief Justice McLaughlin, or former Chief Justice McLaughlin, Justices Major and Justice Bastarache agreed with Justice Deschamps that the ban on private insurance violated the Quebec Charter. However, they further found that the prohibition on private insurance also violated Section 7 of the Canadian Charter. These three justices held that in circumstances where governments are failing to deliver health care in a reasonable manner, the prohibition on private insurance interferes with rights to life and security of the person. The three justices found that the ban on insurance was arbitrary and so not in accordance with Section 7 principles of fundamental justice. Pointing in particular to the Kirby report, which described parallel healthcare systems in other Western democracies, the three justices dismissed the extensive evidence at trial around the impact of private finance on the public system. And in fact, Chief Justice McLaughlin characterized this in her decision as competing but unproven common sense arguments amounting to little more than assertions of belief. Justices Binney, Lebel, and Fish, in dissent, took issue with the Chief Justice's approach to the evidence, which directly contravened the evidentiary findings of the trial judge, something to which appellate courts are generally expected to defer. The Binney, Lebel, and Fish found that the ban was in no way arbitrary, but instead was designed to protect the single-payer system. In the result, 4 of the 7 justices found that the ban on private insurance violated the Quebec Charter, and there was a 3-3 split on the constitutionality of the ban under the Canadian Charter, which is why the decision only had direct effect in Quebec. The Shaoli decision was widely condemned by constitutional lawyers and health policy experts alike. The decision was criticized first for the majority's total disregard of the evidence relating to the impact of private insurance on wait times and the impact of private funding on the integrity of the publicly funded system. And in fact, many in this audience criticized the decision in this regard. However, the doctrinal basis for the majority's judgment was equally objectionable and I would argue immoral. The majority justices proposed a reading of Section 7 that appeared to affirm a charter right to buy, but not to receive health care based on need. And in fact, the court, having found that people were left to languish and even to die on waiting lists, nevertheless issued a remedy that was only available to those who were able to pay. So what's the significance of the Shaoli decision for the Canby case? With the retirement of Chief Justice McLaughlin, there is actually no judge left on the Supreme Court of Canada who sat on Shaoli. Unlike in Shaoli, which ran largely under the radar outside Quebec, the Canby case is being argued in English, and thanks to the BC Health Coalition, Canadian Doctors for Medicare, and many others who are here today, Canby is being argued in the glare of the public spotlight. In my view, there are two aspects of Shaoli that remain critical for the outcome of Canby. First and most immediately is the issue before the Canby court. Second, the broader question of the role of charter review as a healthcare accountability mechanism. The key evidentiary issues in Canby, which were present in Shaoli, include what progress governments have made in addressing public perceptions and reality of undue wait times for care within the public system. The case also raises the issue why, as the Quebec government argued in Shaoli, are private funding and care not a solution? Equally important in my view is the broader question of the role of the Charter as a healthcare accountability mechanism in Canada. Most health policy experts and commentators in Canada, and many legal ones, have taken the view that the charter review, and the courts have nothing and should have nothing to say to the healthcare system. So while, for example, the Romano report failed entirely to mention the charter, the Kirby report did not. In his report and in his Senate intervention in Shaoli, Kirby advocated for a reading of Section 7 as the source of a right to private versus public care. And it was this reading that was adopted by the majority of the court in Shaoli. If wait times and other systemic barriers and inequities in access to care threaten life and security of the person in Canada, including especially of Indigenous people, people living in poverty, and other disadvantaged groups, the response of governments and the health policy community can no longer be, in my view, that these are matters exclusively of public policy rather than of basic human rights. Issues falling within the sole purview of legislatures and governments, and falling beyond the purview of courts. Section 32 of the Canadian Charter provides that the Canadian Charter applies to all matters within the jurisdiction of legislatures and the government, including their delegates. The court has found that this includes publicly funded hospitals when they are delivering publicly funded care, and I would argue by analogy that the Charter applies to physicians delivering publicly funded care. In order to argue effectively for solutions to wait times and other barriers to care within the public system, and not as Brian Day is seeking through the dismantling of Medicare, we must, in my view, stop insisting that the Charter should simply ignore the healthcare system and that access to health claims are non-justiciable. The Shaoli and Brian Day litigation show that even if this were desirable, it is no longer tenable. Instead, as defenders of the single-payer system, and most especially in our interventions inside and outside of court in the Canby case, I would argue that we must vigorously advocate for a reading of the Charter that reflects and reinforces the human rights principles that underlie the Canadian single-payer healthcare system. Principles that, by the way, should underlie the Charter of Rights itself. And here I use the words of Justice Binney in his dissent in Shaoli, a system which is mindful and protective of the rights of all and not only of some. Thanks very much for your attention, and I look forward to comments and questions later on.
Thank you very much. That was a fabulous recap of these cases and its implications today. So our next speaker is Dr. Greg Marchildon, who is the Ontario Research Chair in Health Policy and System Design at the Institute of Health Policy and Evaluation at the University of Toronto. He has served as Deputy Minister of Intergovernmental Affairs and as Cabinet Secretary and Deputy Minister to the Premier in the Government of Saskatchewan. He's the author, as you may all know, of numerous academic articles on Canadian federalism and comparative health systems, as well as a number of books. Welcome, Greg.
Well, thank you very much, and I note that you didn't say that I was Executive Director of the Romano Commission after the comment about the Romano Commission's lack of study of the Charter and reference to the Charter. What I'm going to do is just basically rummage through history for some policy lessons today, and my metaphor will be we're going to be looking into the policy dumpster, if you like. I personally like dumpster diving. I do it from time to time. About 30% of my time I'm rummaging through history. And the history of private finance is particularly in the early days of Medicare, is particularly rich. It's also messy and somewhat smelly, as you would expect. So I want you to join me in doing a little dumpster diving, and just hold your noses. I think you'll enjoy it. Now, I think that there has been a pretty major shift in the country in the last 15 years or so. You can always expect that there is going to be a group that will be opposed to Medicare for largely pecuniary reasons. They have motive, they have incentive, and that group can be fairly predictable. What's less predictable is the general public. And I think that there has been this slow-growing popularity in the idea of private finance in the general public. Part of this is driven by the dissatisfaction with aspects of public Medicare, and probably this was expressed most vividly in 2003 with a film which was extremely popular in Quebec and the rest of the world, probably not so much in English Canada, but I certainly have had lots of discussions with colleagues in Latin America about this particular film. Now, Denis Arcand is a celebrated filmmaker, but for those of you in the room, and I would imagine many of you have seen the film, really, in a sense, celebrates the idea of private finance breaking what is described and shown to be many times in the film to be this very unhappy and somewhat grim status quo in which you have this inflexible bureaucracy, corrupt unions, and nothing moves. And first, private finance through attempting to, through the very wealthy son, to get his father to the United States when his father insists on treatment in Montreal. Then his son begins to bribe everybody in sight to make things move again. And it's a real indictment of the Canadian system. It's certainly not an image that I relate to. I don't think it's a particularly fair image, but there are places in Canada where you can see something similar. And certainly it's the dominant image that was created in the rest of the world about Canada. And I once was in a conference with a Brazilian colleague who was a very famous specialist, and he ran a large part of the health system in Sao Paulo, which, as you know, has got a population almost the size of Canada. And after I got up to speak, he got up to speak, and he just looked over at me and he says, well, we all know what the Canadian health system is like. We've all seen the film. We can ignore everything he's had to say about it. national Medicare was really built on an uneasy compromise that came out of a 23-day doctor's strike, something called the Saskatoon Agreement. Now, this is uneasy compromise certainly created a universal system in which all residents are enrolled on uniform terms and conditions, but it also stipulated the right to opt out by physicians, and what is not as well known as well, the right at the time to extra bill, something that the Saskatchewan government was very concerned about, but it was written into the original agreement. It also institutionalized, centralized bargaining, what Carolyn Toohey calls a duopoly, that was replicated in province after province, in which you had this executive arrangement between the medical profession and the provincial government, and has dictated the direction of Medicare ever since. So what I'm going to do is a little bit of dumpster diving beyond Saskatchewan and look at Alberta and British Columbia. And I'll start with Alberta because actually there were alternatives created to this system of Medicare established by Premier Manning and a social credit government, first in terms of universal hospital coverage from 1950 to 58, and then in terms of universal medical care coverage, which wasn't actually so universal, but was an approach from 1963 to 1968. Now, the various aspects of it include the fact that their user fees were part of the system from the beginning, as well as extra billing, that it was voluntary, not only at the individual level, but at the level of local governments. Local governments could opt in or opt out, and that it was also a system in which it was based upon subsidy of private health insurance. And those that were deemed to be sort of, in a sense, the poor enough and could demonstrate that would be given a subsidy to purchase private health insurance, again, if they wanted to. In British Columbia, the experiment was between 1965 and 1968, and a system that became known as Bennett Care. That's what it was called by the media. And there, W.A.C. Bennett, the Premier, decided to create a system that was in between the Saskatchewan model and the Alberta model. So it was a system based, again, on private health insurance, but on not-for-profit private health insurance. He kicked out the commercial carriers and only allowed the not-for-profit carriers. He created a package of basic coverage. It wasn't identical, but it was reasonably close in terms of what would be covered. And initially wasn't going to have a public option. It was entirely to be carried by private not-for-profit carriers, but one of the private carriers, MSA, Medical Services Associate, which was the physician-based carrier, refused to pick up what it considered to be the poor risks and insisted on the government doing it. So the government had to set up something called the British Columbia Medical Plan, which became the public option. And there were user fees, both in terms of hospital and physicians, as part of the plan as a kind of a deterrent fee. So we had these two systems in operation, and when the federal government introduced the Medical Care Act, there was a fair amount of negotiation over about a 2 to 3 year period, which Manning attacked the federal system, Bennett negotiated. They attempted to keep their plans in place, but both were forced to, in fact, change the plans in order to comply with the federal criteria, which reflected the Saskatchewan design in almost every respect. So we knew that experience, but one of the reasons that the federal government wasn't willing to go along with Bennett Care or Manning Care was that they just didn't come close to covering 100% of the population. In the case of Manning Care, they could only get up to about 70-75%. In the case of Bennett Care, they could only get up to about 90% in that voluntary approach. And they had to in fact goose the rates in terms of subsidy to even get it up to 90%. The next part of the experimentation with private finance occurred through user fees. Again, not something that is well known. But in 1964, a new government was elected in Saskatchewan, a fairly conservative liberal government under Ross Thatcher. And in 1968, in April, he introduced deterrent fees. And these fees remained in place until August of 1971. So fairly about 3.5 years or so. And this was a very interesting little experiment. User fees both in terms of hospitals and in terms of physicians. And there was a study done by Beck and Horn many years later in 1980 that looked at the situation before, during, and after the implementation of user fees. It is the only real study of user fees in Canada. And they found that in the end, in fact, that the effect of the user charges was simply to transfer costs from the public to private budgets, with the burden falling disproportionately on sicker members of the public. That was their conclusion after this fairly extensive study. I would say that many have forgotten about this study. We haven't had the opportunity for a similar sort of what I would call experiment in user fees. So I think it's worth going back to that. The next picture that I have on screen is Adrian Dix, because in the last 36 hours, and by the way, he's the Minister of Health in British Columbia, for those of you not from Western Canada. But British Columbia recently got hit with a $16 million fine from the federal government because of the amount of extra billing that was going on. So the BC government responded by, in fact, creating legislation and fines, or using legislation to fine the private surgical clinics and MRI clinics that were engaging in this practice. And once again, Brian Day came out and said that the action by the BC government was draconian, considering court action against it, and will result in the closing of a number of the 56 private surgical clinics and dozen or so private MRI clinics in that province. So we'll see whether Brian Day once again uses the charter against this attempt to close down extra billing. Now, there is a connection, a very powerful connection between ideology and design. I tried to lay that out here in terms of the starkest differences between, on the one hand, the Alberta programs in the 1950s and 1960s, and the Medicare plan that was created in Saskatchewan that became the template for the rest of the country. And one of the most important aspects of the Saskatchewan design is that coverage is based on uniform terms and conditions, and that you're not to differentiate among beneficiaries on the basis of health, age, contribution, or income. And I think that's the important point, because in Canada, Medicare is not an insurance scheme. It is, in fact, a system that is based upon coverage which in turn is based upon the simple residency, and if you apply it across the country, not just within 13 provinces and territories, you can call that citizenship. And it's a very different approach than, for example, the Affordable Care Act in the United States, where you see many of these debates occurring, but, you know, the whole issue of compulsory versus voluntary, which is going on right now, was very similar to the Manning-Douglas debates of the 1950s and 1960s. The subsidy of private health insurance versus the creation of a system of coverage based upon residency or citizenship. And of course, the earlier debate when they were designing the Affordable Care Act and the issue of the public option. And that public option was dropped. Unlike Bennett Care, where there actually was a public option. So what are the policy lessons that we can draw? Well, the first policy lesson is fairly simple. And I would say to some people in this room, and I would say publicly, don't pull out some old trash from the policy dumpster and pretend that it is something new and innovative. And that's a lot of what we're talking about in terms of private finance. 2, user fees. We've experienced them in this country since Medicare was introduced. We know their result, and it's based upon a system which is still the system in place today. So we should have a pretty good idea of what private financing through user fees would produce. Number 3, on private health insurance, when we're talking about parallel or competitive private health insurance, we should understand that the introduction of that system will create a system in which it's almost impossible to have similar coverage, much less coverage on identical terms and conditions. And the other aspect of that is that to have a very viable system of private health coverage, and here we can go again back to Medicare in its origins. In Saskatchewan, they did permit, because of the Saskatoon Agreement, private health coverage. It acted mainly as a post office. But in the case of Bennett Care, that was the one thing he was allowed to keep, and the private health insurers continued. But because they were only making about 5% rates of return, they disappeared within about 4 to 5 years. And the same thing happened in the case of the physician-based carriers in Saskatchewan. So we know that it requires more than a 5%, if you say, tax on public funding to keep that system going. And that we'll hear a little bit more about Australia tomorrow. But what you need to do to make such a system viable is have a great deal of public subsidy. And unfortunately, when we use tax expenditure subsidies, we don't count them up in the cost of health care. And we need to begin to do that. So thank you very much today, and I look forward to the questions later.
Thank you so much, Greg, for just a wonderful sort of recap of history. By the way, these two speakers have had a just recent and really phenomenal article in The Lancet on Canadian healthcare, so please avail. It's my pleasure to introduce our last speaker, Dr. Danielle Martin. She's a family physician and assistant professor at the University of Toronto. She practices at Women's College Hospital, where she's also vice president of medical affairs and health system solutions. She's a leader in the debate over the future of Canada's healthcare system, appearing regularly on CBC television as a columnist in Chatelaine Magazine and regularly at speaking events. Welcome, Danielle.
Thanks very much, Robyn. Merci, Colleen, de m'avoir invité aujourd'hui. I want to begin by acknowledging my colleagues, Drs. Ashley Miller, Dan Raza, and Lisa Abraham, whose work is the foundation of this talk and of the paper that will come of it in the weeks to come. So in Canada, we often talk about Medicare as a defining social program. But of course, as we are going to be talking a lot about over the next 24 hours or so, Medicare is as much a set of regulations on physician behavior as it is a social investment. The very bedrock of our public health care system is as much about what doctors are allowed to do and not allowed to do as it is about the public financing of the care that patients need. So the ban on extra billing and the ban on dual practice are at the core of Canadian Medicare, and it is these regulations, as much as anything else, that ensure equitable access to medical services in our provincial plans. And I'm going to pause here briefly because I know we have a mixed audience here tonight to quickly define those terms. Extra billing essentially is a case in which, you know, I'm a family doctor, you come to see me, I examine you and I make a diagnosis and I propose a treatment plan and you leave and I send a bill to the government for whatever the centrally negotiated rate for that service is. Let's say it's $30, but I'm a really awesome family doctor and therefore I think my service is worth $45, and so I will bill you the additional $15. That's extra billing, outlawed in all Canadian jurisdictions. Now, unlike private insurance, which as I know we'll get into in some detail, is not actually illegal in many Canadian provinces and territories. The second is the ban on dual practice, which simply says that in all provinces and territories, with the notable exception now of Ontario, as a family physician working in the healthcare system, if I don't want to bill the government for my services, I'm not obligated to do so. I can opt out of the system and charge my patients directly for my care, but I cannot charge my patients 1 penny more than the public system would reimburse me in most Canadian provinces, BC being a notable exception with a complex set of rules. And therefore, the fact that I cannot be billing in the public system and in the private system, you know, Monday, Tuesday, Wednesday, going back and forth between the two, and can't be, in most cases, charging more money for my services outside of the public system, the financial incentive for me to do so is essentially eliminated. And those are the core regulations that protect Canadian Medicare. They are regulations that do not actually affect what patients can and can't do. They affect what doctors can and can't do. And just as Medicare has had a profound effect on Canadian patients, essentially eliminating the financial barriers to medical and hospital care that defined so many people's lives in this country in the 1940s and 50s, Medicare has also had a profound effect on doctors. It has insulated us, something which I think many doctors don't realize, from the most heart-wrenching decisions that many of our American colleagues have to make every day with respect to uninsured patients. It has protected us, something which I know people don't talk much about, from the deep ethical quandaries of dual practice and self-referral. And as a result of the highly privatized model of Canadian healthcare delivery, which Greg alluded to and I'm going to talk about a fair amount today, Medicare has also granted us extraordinary clinical autonomy, perhaps more clinical autonomy than virtually any other healthcare system in the developed world. But of course, in spite of all of those upsides, our public healthcare system faces significant challenges, and the practice of medicine in Canada isn't always easy. So as the token clinician here this evening, I'm going to try to describe a little bit, and I should say that I represent no one but myself here, but I do think I have some observations that may be of some use. Some of us may be easily lured by promises of improvement under a multi-payer system. And this is especially true, by the way, when people offer up facile or superficial international comparisons, many of which I know are going to be thoroughly debunked over the course of tomorrow's conference. And despite, this is amazing to me, despite the tremendous fissures that our patients face when it comes to dental care, to prescription drugs, to access to psychological services, and so many other areas where we see private financing taking the lead in this country's healthcare system, In spite of those fissures, many doctors, just like many members of the public, seem to hold out hope that somehow private payment's going to fix it all of the stuff that ails Canadian Medicare. And of course, the two important court challenges that we've heard a lot about from our experts so far this evening have been led by physicians. Both the Shaoli case in Quebec and now the Cambie Corporation case in British Columbia, which resumes in Vancouver on Monday after a hiatus of many months, have doctors as their poster children. So if the Cambie case is won by the plaintiffs, the result will be not just striking down a ban on private insurance, but as Martha has articulated so well, a striking down of the regulations on physician behavior that we've spoken of. And this will almost certainly, I would suspect, be immediately followed by a slew of new regulations to try to protect the public interest in the face of parallel private pay, just as we have seen happen in many other countries. There is no system in the world in a high-functioning environment where private pay is just allowed to run rampant without any regulation. So I do not think for a second that the elimination of these two particular regulations will be the end of the conversation, which of course is why we're having this conference. So it seems we can't really talk about healthcare financing without talking about not just physician financing, but physician behaviors. And what I'd like to do in the remainder of my time is to begin to explore the relationship that Canadian doctors have had with private finance in order to ask what role can we expect doctors to play in a post-Cambie world, and what are the cultural factors that shape that role. So a very brief historical reminder, and it's always dangerous to follow a real historian. You know, the Canadian physician relationship to Medicare, as we all know by now, got off to a pretty rocky start with the doctor strike in Saskatchewan in response to the introduction of government-financed medical insurance. And the resolution of those conflicts, which, as Greg has articulated, was known as the Saskatoon Agreement, laid the groundwork to what is a very particular Canadian approach to physician autonomy in the face of public financing. In short, doctors agreed to be paid publicly but remain independent entrepreneurs, not employed by the government, not employed by hospitals, not really accountable to any institutional structures or frameworks for their participation in a publicly funded system. And of course, we were and remain accountable for the care of individual patients as a self-regulating professional. This is important. Doctors in Canada are not unaccountable. They are deeply accountable as a self-regulated profession for clinical competence, for ethical behavior, for the care that they provide to individual people every day. And we wouldn't, I assume, want it any other way. But it's the notion of the physician as a player in a system that was left on the cutting room floor in Saskatoon. And that has had very far-reaching ramifications indeed, many of which have been written about by my co-panelists and other folks who you're going to hear from tomorrow at this conference. But public payment was and remains a significant accomplishment. Doctors, by and large, actually, I think, quite quickly came to see that it wasn't such a bad deal at all, because unlike patients, governments seem to, by and large, pay on time. And as, of course, we know, Medicare turned out to be wildly popular with the public. And so in the ensuing decades, the pro-private stance of physicians sort of began to bubble underneath the surface. Every once in a while, it would break that surface with events like the doctors' strike in Ontario of 1986 in response to the implementation of the Canada Health Act, or the election of Brian Day as president of the Canadian Medical Association in 2006. In recent years, vocal physician support for private financing has wrapped itself primarily in the flag of patient access. And advocates have, I would say with remarkable success, neatly sidestepped the fact that extra billing mostly pads the wallets of doctors, and that dual practice in nearly every international jurisdiction is a source of lucrative side work for physicians who are paid much less than Canadian doctors are in their public systems. Instead, arguments often present a second tier as a safety valve for a stressed public system. And of course, we see this clearly in the rhetoric coming forward in the Cambie case underway in BC. And I'm going to come back to why these arguments are particularly important for mainstream doctors. At the same time that you have those physicians who have been vocal opponents of the single-payer model in Canada from the very outset, there has also always been a counter-narrative, physician defense of public financing. And Jackie Duffin summarized this history very well at the AMS conference not long ago, where she traced the origins of groups like the Medical Reform Group, which rose up in Ontario in response to the Ontario doctor strike in '86, and Canadian Doctors for Medicare, which was founded when Brian Day became president of the CMA, in part because of concerns that a person who regularly liked to call himself Dr. Profit in the media might not represent the views of all physicians, or certainly not those in Canada who support Medicare. And I will say that although they're often depicted as ideological, these pro-Medicare physician groups have traditionally prided themselves on the evidence base that they call upon in support of public financing. And I'm not going to run through that evidence base. It's not the focus of my talk, and Greg and Martha have alluded to it in their comments. So it seems to me that perhaps there is sort of a battle for the soul of the medical profession between these two groups. Those who opposed Medicare from the very start and who would now like to see it struck down in the courts, and those who broke the strike in Ontario and still today will go to the ramparts in support of public health care, including as interveners in the Canby Corporation case. In fact, though, most doctors don't think about these issues at all. It's the silent majority that I think we should be interested in. Those who experience every day in their work considerable tensions between what they believe to be the best for their patient and the interests of the so-called system in which they work. Those are the people who we need to better understand. And that brings me back to the discussion on waits. I really can't emphasize enough the impact of wait times on the daily lives, not just of Canadian patients, who of course should be paramount in these discussions, but also on the lives of Canadian physicians. Every day, these essentially decent people get up to go to work, and they face individual after individual after individual who are scared or angry and are waiting. So think about it. I mean, the average Canadian citizen might experience a significant wait. I'm not talking about a clinically significant wait, because we don't have all that many of those, but an emotionally significant wait in their own life or the life of a loved one once or twice in their lives. But if you work in the healthcare system, you're seeing that multiple times a day. And while the system absolutely moves quickly and is very effective for those who are acutely ill, and while our outcomes for a variety of acute and chronic diseases are very good, so I am not at all suggesting that these waits necessarily have an impact on health outcomes at the end of the day. I don't actually think that they do. But every Canadian doctor in their daily work experiences real frustration trying to get patients timely access to non-urgent, but nevertheless medically necessary services. Now, I've often said that one of the great gifts of medical training is that it teaches us to really see the individual sitting in front of us. We are taught over and over in medical school about the primacy of the doctor-patient relationship. To paraphrase one of my own heroes, Dr. Don Berwick, there is something that happens when the door clicks shut in the examination room that makes us feel that we have entered a sacred space. And I believe that to be true. But too often, our emphasis on individual patients has resulted in an interpretation by Canadian doctors, at least, that the system is something from which patients need to be protected. And the system is something that can't be allowed into the examination room. Systems are about, as a colleague of mine recently put it, heel clickers, where I think people like me, hospital administrators who click, 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 click down the hallway, you can hear them coming, going about their totally unimportant bureaucratic duties, right? And few mainstream physicians would stop to think that the system is actually the infrastructure that allows us to take care of our patients in the first place, or that the solution to wait times lies in reorganizing our own relationship to that very system. So I hope you can see why that aspect of medical training, which is core to medical culture in Canada, has made physicians especially vulnerable to arguments in support of privatization. These people are doing what we all do. They're looking for easy solutions to complex problems, and they're being inundated constantly, whether it's through the medical post or in the doctor's lounge, with pro-private funding arguments. I think this is critical because, of course, the real solutions to wait times, as we know from the evidence and our own experiences in Canada, have nothing to do with private financing. The real solution to wait times has to do with the way that we organize our care delivery. They have to do with things like team-based care, the kind of stuff that Michael Rackless has been talking about for years, with group care, with virtual care, centralized intake for specialty care, the application of queuing theory, high-performing primary care that deals with people's needs in the place where they're most likely to be found. None of that, folks, not any of it, can be implemented without doctor participation. And that is the deep conundrum of the Canadian healthcare system. I want to finish by saying a few words about something else that's been going along on the sidelines that many of you may not be aware of, which is that even as this case plays out in the courts, and even as governments and health system leaders try to grapple with waits across the country through public solutions, the medical profession has not been stagnant. It has been evolving. And there's a quiet revolution that's been playing out in Canada's medical schools that I want to draw your attention to. This is what we now call the era of social accountability, an era in which medical education is now explicitly placing emphasis on the notion of a social contract as part and parcel of medical professionalism. Medical students today don't bat an eyelash at conversations about health equity or health systems as redistributive systems. They don't worry about the idea that the purpose of a profession is not just to serve the individual patient, but to contribute to systems of care that serve populations of people. And we're seeing this play out in organized medicine through the Canadian Medical Association. I would note that we've had a succession of CMA presidents post-Brian Day, whose own careers actually embody this notion of social accountability. We see it among our trainees, with groups like the Canadian Federation of Medical Students and Resident Doctors of Canada engaged in very significant advocacy around things, whereas they used to, in my day, advocate mostly about tuition rates being too high for medical students, now they're, rushing Parliament Hill on pharmacare. So there is something happening in our medical training that is not to be underestimated. I want to conclude today by saying that the relationship of the medical profession to private payment in Canada, of course, has been and always will be complex because there is no such thing as a single monolithic medical profession. As I've tried to illustrate, there are groups of doctors who feel deeply and act boldly on both sides of the spectrum. But the majority of physicians are not thinking about any of this. They're just trying to do their best to find workarounds for very real limitations that they encounter in taking care of patients every day. The next generation is being trained with a very different set of views about what autonomy means and what accountability means than preceding generations. And I think that if faced with defeat at the hands of Brian Day and his buddies, our governments are going to need to take that shift into account because actually what it is that is being advocated for in the courts in British Columbia is not a vision of the future of medicine that this generation of doctors is going to have much of an interest in participating in my view. But it is ongoing challenges to access, quality, and timeliness in our public healthcare systems that risk undermining the commitment to Medicare among doctors as well as patients and the general public. And that's why I remain of the view that the best antidote to privatization rhetoric, both inside the courts and outside them, is just to make Medicare better. Thank you.
A very special hand to all of our speakers. I think they are just fabulous and a great way to kick off essentially what will be a great question and answer period. So don't all rush at once. The mics are up there and there. When you get there, just tell us who you are and what your question is. And while we're waiting for that, good, I get to ask a question. I have two questions for the panel. One question is this, and I guess I'm kind of deep in the, but rapidly leaving from from being involved in sort of the research funding enterprise, but one concern I have is the increasing pressure on public Medicare of essentially new technologies, new gizmos, new this, new that, especially under the umbrella of personalized health, where we're talking about an increasingly everybody is their own special rare disease practically. It's not to say that that's not the best thing that we could possibly do for people, but that means the unit cost per person is going to be higher. And I just see that the avalanche of how much funding just in Canada alone we've put into this, that's probably 80% of all research funding goes into this basket. So I'm concerned about that and whether or not we have systems to deal with the pressures of this in a rational way. So that's issue number one. And issue number two is really a comment from Danielle, if she has one, or others, about the changes that are happening in terms of the gender mix of the medical profession. So at the beginning, we were talking about whatever 95% are male physicians, where we're talking about where Greg started us, to now essentially, I would say a greater proportion of women are entering medical school than men. And I just wondered what these or other trends that you think are relevant to the discussion are going to have on the dialogue going forward.
Why don't you go ahead, Danielle?
Well, you start with the easy ones, right? Just a quick comment on personalized medicine, because I think this is a real tension. Of course, it's not unique to Canada.
No.
This tension, it's an international, it's a global trend. And I think I like to think about it not as a phenomenon in its own terms, but as a phenomenon in tension with the concomitant rise of population health as a real movement. Because on the one hand, we want to be dealing with everybody as an N of one, and on the other hand, we want to be implementing population level initiatives that are going to improve the health of groups and that are going to get more upstream, see social determinants of health. So I think, to me, I think it is I do not think we are remotely ready for the conversation. I do not think we have language or tools to deal with it. I don't think we have ethical frameworks to deal with it. But I think it is better tackled or understood as a trend it's not about a competition, but a trend in tension with other trends, because I think you can never get at these things in absolute terms. You can only get at them in relative terms. We have to talk about them as trade-offs. How many kids can you immunize in exchange for one genetic therapy? How many dollars of increase in social assistance, poverty reduction, and therefore health improvement can you get for super expensive fancy cancer drug? Unless we talk about these things in relative terms, I think it becomes a mug's game, because everybody's got a legitimate story if they're the only citizen. It's only when they have to live in a country with a whole bunch of other people that it becomes complicated. Just a quick note on the so-called feminization of medicine. Like so many other sectors, this is a feminization of the grassroots, not of the leadership. And this is where we are going to get a problem. We do not see women rising in the ranks of medical leadership at rates that one would expect to see, given their numbers in medical training. We do not see them in the high-earning specialties at rates that we would expect to see. We do not see them on the bargaining teams. So I have lots of theories about what the relationship of physicians would be to our health systems if women had been negotiating the collective agreements. I think that there is a, as there has been in so many other sectors, there is a lot of work to do yet. And so, it's great and wonderful that we're seeing women entering medicine in large numbers. I think it will, over time, change culture. But we have the same C-suite, boardroom, leadership problem in medicine that we have in every other sector of society. And so we're not ready yet, I think, to be able to really say much about what it's going to mean.
Thank you. Greg, did you have
I would just make a quick comment about that issue of just ever-rising costs and what mechanisms do you use to put constraints on them? And there's no question that is an unstated preoccupation for judges when they're dealing with these cases, and why the cases where patients or doctors are claiming a right to private care have been successful, where cases where patients have claimed a right to publicly funded care have gone absolutely nowhere. And the courts have been very reluctant to accept the idea that the state might have a positive constitutional obligation to ensure access to care. It is completely motivated by this widespread concern about floodgates. And again, the point I would make is the one that I made earlier, that the Charter does provide a framework for dealing with wait times as a form of rationing. And the Charter also contains systemic equality guarantees, which are much more consistent with a public health perspective. So the idea that spending a lot of money on acute care means you're not spending on social assistance. The notion of a human rights accountability framework for healthcare is well established in international human rights law. Other jurisdictions have wrestled with this under the International Covenant on Economic, Social, and Cultural Rights. We have general comments about how you balance equality and the notion of individual access or individual rights. And my argument would be that the debate can be enriched by seeing it through a human rights lens, and that ignoring that lens simply leaves the field wide open to those like Senator Kirby or Dr. Shaoli or Brian Day, who are advocating for individual rights, which are a lot more appealing to courts because they appear to benefit the wealthy, so I mean class friendliness to the claim, and cost the state nothing, do not require courts to order governments to spend money they don't want to spend. And I think in the same way that it's been difficult within the healthcare system to try and create a framework for actually addressing what's incredibly hard about these trade-offs, ignoring them or trying to sidestep them is just delivering us, in my view, to the hands of those, the point you made, with simple solutions, and that is true in the Charter context as well.
Thank you, Martha. Okay. Yes, could you just mention your name and where
Thank
you're
you.
from?
Thank you. My name's Alan Rock.
Oh, yes, of course. I need my glasses, sorry.
And may I say, what a great way to start this conference. The three panelists made fabulous presentations, and we're grateful to each of you for what you contributed as we start this important discussion. Just a footnote before I ask my question, we've talked a lot about the courts, but the other part of the context in which these issues are going to be determined is the political context, and with the seeming imminence of the arrival of Jason Kenney in Alberta and Doug Ford in Ontario, we better brace ourselves for a very different political context than we've seen over the last little while. My question, though, has to do with the presentation that Dr. Martin made, and it was wonderful to hear her make the fundamental point that none of the changes we really need to resolve the issues in Medicare are going to happen without the participation of the physician. In the 5 years that I spent as Canada's Minister of Health, one of the things I learned, and yes, even a lawyer can learn these things, is that primary care reform, primary care improvement, is fundamental to so many of the issues in the Canadian healthcare system. And in fact, the federal government invested substantial sums in what was called the Health Transition Funds. Greg Marchildon, as a historian, may remember that, developing workable models of primary care reform. But the obstacle to implementing them broadly across the country, apart from Mike Harris and Ralph Klein, in other words, Doug Ford and Jason Kenney, was the leadership of the profession. The hope at that time was that with women coming into the profession in such great numbers, that resistance might change because women take a different approach to partnership dealings, to consensus decision-making, to teamwork, and perhaps to the practice itself. So I come to my question. You spoke about the feminization of Medicare and the fact that it hasn't yet translated into the leadership of the profession. But is there evidence that over the last 10 or 12 years, the increasing participation of women as physicians has softened some of the barriers to implementing changes toward team practice at the ground level in Canada?
So it's an incredibly thoughtful question, obviously, and I would say I do not know that there is evidence, although I will defer to my colleagues around the room who may know of evidence that I'm not aware of, but I do think there is an accumulation of anecdote that suggests the answer to your question is yes. And not only that women entering the profession are more open to team-based models of care or, functioning in primary care groups or working with other flavors of healthcare providers. I mean, I was asked to talk about doctors today, but of course, there are many other critically important healthcare providers in the system, et cetera. And that it's not just women, that actually the new generation, if you will, of healthcare providers entering the scene are much more open to these things. We know this in part because of surveys which indirectly point in this direction by asking new graduates, how likely are you to want to sort of go out and hang a shingle and hire a secretary and start a filing system and buy an EMR and run a small business? And the number of graduates who say that that is their vision for their career is tiny today. And so the alternative, of course, is team-based care groups, coming into a turnkey environment. What one hopes is that the turnkey environment we will offer them will not be solely walk-in clinics owned by chain corporations, but actually true population-centric, patient-centered medical home version primary care. And that will require some public investment. And it's happening. It is happening across the country. But yeah, it's happening slowly. Do you want to add anything to that?
Okay, so I'm just going to turn to this mic and...
John Sproul, proud Canadian, but living in one of the 13 different health systems, coming from Alberta, and that I just think it's an interesting aspect in the Canadian environment of talking about Medicare things and having all the different kind of multiple systems. But just a question of looking to the future, because a lot of the rules have been developed around coverage when we talk about Medicare for physician services and for hospital services. And as we start to move where a lot of things that might be considered to be medically essential or important to be publicly covered will not be delivered by a doctor and will not be delivered in a hospital. And so I just don't know if there's any kind of comments as we move towards a lot of discussion of payment for outcomes or payment for a service, regardless of who does it. That becomes a real challenge as we create legal systems of what's in and what out as we move towards team-based care, what's fully covered, what's partially covered. And Danielle, I don't know if you have any kind of comments, if there's a bunch of services perhaps you do now could be done by other providers, and in some instances non-health providers, and how does one prepare for that future as we quickly are moving forward where it won't require a physician to be involved? Although I do welcome the comment that you do want that click of the door where someone acts as your individual advocate and isn't a toady of the big machine in how we deliver healthcare. It's a dilemma that you have to deal with. But that preparing for the future rather than just focusing on where we are now.
Well, if I could just open this up by saying, first of all, that Medicare is a peculiar concept because it's really, if you think of it simply as a set of national criteria or standards, it's really a floor. And every province and territory, any government can choose to increase universal coverage in the way that does. And in fact, that has been going on to a limited extent. In other cases, the coverage is based on categories or based upon need or income, etc. And provincial and territorial governments have been always, in a sense, creating legislative and regulatory frameworks for those. And I think it's, for me, it seems that there's nothing blocking any provincial government from moving ahead and creating a much more integrated system, and some, in fact, have been doing that. And in fact, a lot of the reforms in the early to mid-1990s were about integrating services across the continuum from the so-called Medicare services to so-called non-Medicare services. And to greater or less success in terms of that. So there's already, I think, a lot of experience across the country on this. And going forward, it would be great to be able to collect up some of that experience and use it much more effectively than we have. We tend to not look at what's going on in other places. And every time I talk about healthcare, not Medicare, but healthcare, the reference point is always where the person sits in terms of their province, where they're resident, where they've had the experience. And there's actually a very limited knowledge of what's going on. It's not anyone's fault, it's just that we haven't done a very good job at distributing that. And I think that could actually act as a real lever for innovation, just that spread of knowledge for the future.
Thank you. Okay. I know, Colleen, you're waiting longer, but anyway, I'm just doing this and that. Okay, over to you.
I'm happy in my queue.
Hi there. My name's Dan Raz. I'm a family doctor from Toronto, and I'm the current chair of Canadian Doctors for Medicare. Professor Jackman, I had a question for you, and I wanted to revisit your comments around the Shuey decision. Specifically, why, despite the Supreme Court's favorable ruling for the plaintiffs, we didn't see an explosion or an expansion of private health insurance in Quebec, and what lessons you think we can take for that about what may or may not happen in the Cambie case in BC?
I wish Marie-Claude Prémont were here to answer that question, and I'm tempted almost to send it. I don't know where Marie Carpentier est là, would be better placed than I to answer what's happened in Quebec. My understanding is that certainly the Quebec legal scholars that I know are actually very concerned about the extent of creeping privatization that has occurred in Quebec following Shaoli, that's far more insidious than what it would appear. What I can say is that there has recently been filed by a sort of anti-poverty public health care group coalition in Quebec a claim against the Quebec government for failure to prohibit a whole bunch of illegal billing practices. I can only assume that it's because there's not enough money to be made when it's only the ban on private insurance that's struck down. And that's why Brian Day, and in fact, Deschamps said in her judgment, we're not worried about striking down the ban on private insurance because the other pillars of Medicare are still in place, including the ban on double dipping. And that, I think, is why Dr. Day is going for the whole 9 yards. But the health economists might know better. Mm-hmm.
Thank you.
Yeah, I'd just like to just make an additional comment to that. I mean, one of the things is that obviously private health insurance markets require a broad range of services, a population which is easily rateable, and if not rateable as individuals, that there's the opportunity for group rating. We're all part of that. Many of us in this room are part of group plans and universities. We know how that works. And a lot of that is, flies under the radar. And one of the issues, I think, that is not as well understood is the fact that these private health insurance plans are becoming more and more expensive. And it's going to be increasingly difficult to insure people, aside from the fact that, of course, you have less a percentage of the population because they're working in jobs that are seasonal or that are part-time, etc., they don't have the benefit of these plans. But even those, and many of us in this room, who have the luxury of the benefit of these plans, they're becoming less and less sustainable. And so creating a right to private health insurance is not really going to be an answer. And if you pick a couple of areas like the Quebec government did and a few elective areas, well, the only people that will want to buy that insurance are people with a pre-existing condition or at high risk of the condition, and you're not going to be able to generate a market in that way. So I was never concerned about the Chihuly decision in that respect. I was much more concerned about the knock-on effects if other areas would be changed, but I was also concerned about the politics and the discourse that created, which was a discourse in which, yes, our problems would be solved if we could inject more private finance, rather than dealing with what I would think would be the much more difficult but the real issues that have to be grappled with to improve the system.
Thank you. Colleen.
Thank you very much. What a great panel, and thank you so much for kicking off the conference. I really enjoyed each and every one of your presentations and the discussion. I've been trying to noodle away with my question here to formulate it in a more articulate manner and have failed. So I'll just give it anyway. So one of the things that Justice McLaughlin did in Chihuly was she didn't talk about equity in Medicare when she was looking at what is the government's objective here that they have to assess. She said that there, she didn't say it wasn't this, but she said the objective is to provide some level of reasonable health care for the population, not access on the basis of need and not ability to pay. So not equity as we might understand it, but sort of an okay system for everybody. And then from that perspective, it doesn't matter if we have privates on top of that, right, as we do in many other things in our life. And I think this is actually what's going to be fairly essential for the disposition of the Canby case, is how is the government's objective interpreted, the BC government and other provinces? What is the goal? Because if the goal is actually equity, then some of the laws that we're talking about, they make perfect sense. But if our aspiration is just some sort of okay system that takes care of the poor so they don't complain too much and most of the middle class, and then the rest of us, admittedly, most of us in this room, can then buy the extras that we want, particularly with an aging, very wealthy set of baby boomers looking at their clock ticking down. They don't want to have to share in this common pool so much. So I just wondered how you think about that and whether you think that the goal of Medicare is equity, and then how do we robustly defend that when we don't do that in anything else? Or is it that we just some sort of reasonable standard for everybody, and then so top-ups are fine? Just that little question, which is kind of the kernel of my life.
Who's starting?
Well, I totally agree with you, and I think from a charter perspective, the position that we took was that if those prohibitions didn't exist, that would be a charter violation. Obviously, we were not convincing, but as I say, I think Donna Greshner had made the point, again, looking at the Romano Commission report. She argued that one of the reasons there were so few challenges in the first maybe 20 years of the Charter is that the Medicare system is so consistent with systemic equality guarantees under the Charter. Mm-hmm. So I think within the legal box, that it really is important to go on the offensive in defending the system as an expression of systemic equality. And again, not to keep repeating myself, government's unwillingness to even acknowledge in any way, shape, or form that there could be any kind of positive charter obligation to maintain the healthcare system cripples their ability to make an effective charter counterclaim, in my view.
I guess I would just add a question to your question, Colleen, which is that it seems to me, I mean, I don't know what the purpose of a healthcare system is if it's not equity, not to sound dumb, but I mean, like, as Bob Evans, has said a million times, the purpose of such systems is to redistribute from the healthy and the wealthy to the unhealthy and the unwealthy. I mean, that's why healthcare systems exist. But I'm pretty sure that that's not what the law says in those words. What the law talks about is uniform terms and conditions. And so, in fact, that's not, on my read about equity per se. I mean, it's actually about much more traditional definition of equality. It's not, it's you and I get the same terms, no even if my need is greater than yours. And so I guess what I would ask is, how do you read, what are the opportunities to read equity in? Like, is it the fundamental principles of justice, or like what are the opportunities for governments to declare, and have they taken up the opportunity to do so, to explicitly declare equity as a goal? Because uniform terms and conditions, to me, doesn't quite get us to where we need to be to have the equity conversation.
I actually disagree with some of that. I think that some governments, including the Quebec government, including a couple of other provincial governments in their Medicare legislation, set out the equity basis. The terminology that gets used can be that old-style equality terminology because it's pre-charter, and these folks are, are not sociologists, they're not social scientists, and they will mix the two terms up, so it depends. But also we need to recognize that there is active contestation among governments on ideological grounds. And so, you'll have some governments that will see equity as absolutely critical, and I've worked for a government that made that a very clear principle. But there are other governments that come in and feel very differently. And we had an ongoing dispute with the government of Alberta and Ralph Klein on this. And Ralph Klein would say over and over, no, this is about providing a basic set of services. Don't give me that crap. That other stuff, it shouldn't even apply. And he wanted to break with the Canada Health Act because he saw it as reflecting that principle of equity, no matter how it was worded. And he tried 3 times, but he backed off every time because of the population in his own province. And he had a huge reaction, a huge negative reaction. And in a very democratic way, he backed off. He said, I can't do this because the people of my province will not support me on it. Mm-hmm. Didn't mean he didn't keep trying, but...
Okay, thank you. Emily?
Yes, hi, I'm Elie Quenel-Vallée. I'm at McGill. I have the Canada Research Chair in Policies and Health Inequalities. And I just wanted to come in and put in a plug for tomorrow if you aren't registered yet. So in response to the question about why Quebec and Shaoli and not so much privatization, I tried to provide an answer. And really it's in the title. Shaoli is not so much the cause of privatization in Quebec, it was a symptom. And so we have to dig deeper than what happened in 2006 or what happened prior to that, then culminated in 2006 with Bill 33, which indeed was, as the panelists pointed out, mild in some ways and really had some provisions for protecting, opened up some areas, but other areas were protected, and notably the seal between public and private was very strong. And I don't want to scoop myself for tomorrow, but I'll point to some worrisome trends. And indeed, Danielle and Greg pointed to kind of those stronger, deeper roots that are feeding into what we see now in privatization. And some of those are in light of the Bill 33, some physicians, minority, found it not to go far enough, and they went up to again use the charter to claim that this seal between public and private practice in the same institution was actually countering their right to association. They were struck down. So that's the news flash just last month. And so again, there's all these deep roots, but to speak to your point, Greg, about the rhetoric goes both ways. And what we're seeing now in Quebec is that there is more awareness of what is legal and illegal. And citizens are taking a stand. And with the right institutions, so it takes something like the RAMQ, the health agency in Quebec, to also step up. Now there is more, and certainly the media are taking notice. And so this is, if to a fault maybe at some point with physician remuneration, but it is becoming a big topic of discussion beyond the emergency room crowding, which we used to have a little bit more. So anyway, that was just my comment.
Okay, so good little ad for tomorrow. Very good, thank you, Emily. Okay, so you're the last man standing, and you're going to be the last question of because I know you've been staying there from the get-go. So you're the last question. No pressure.
Okay.
Over to you.
Okay, now that I feel like I'm under a lot of pressure. My name is Sebastian. I'm here representing Canadian Federation of Nurses Unions. I just wanted to start off with an anecdote that I think may be kind of useful for this conversation. My partner about 9 months ago went to the dentist, and had some aches and pains in her mouth. And was referred to a specific specialist, but obviously in the private domain, it's not covered by public because it's all in her mouth. And she had to actually wait somewhere around 6 months with growing pain in her mouth for the specialist to see her for the first. Basically for the first interaction, just to be able to sort of diagnose and provide a treatment plan. I thought it was kind of instructive, right? Because there's this notion that all wait times will be fixed, but actually in like an entirely privately funded system, there's only a few of those specialists in Ottawa, and lo and behold, there's a long wait time, right? With a condition that may not be, clinically urgent, but is very, very emotionally costly and causes a lot of pain. So that I just thought I'd share that with folks. The question that I have is actually a pretty simple one, kind of a systems level one, and maybe it's one that Mr. Rock would be able to answer as well. It's something that's bothered me since I took my first health politics class in university, which is essentially, in Canada, do we have a system whereby we're always going to be facing a certain level of cost pressure just because of our sheer size? Like I often see these comparators in per capita spending, healthcare spending, right? And the U.S. is way up there, and then Canada is a bit above the pack. But the pack is really like Denmark, Netherlands, UK, New Zealand, which are far smaller and more densely populated. It just seems to me that there may be an element or a layer in there that's sort of something that we just have to live with as a country that is so massive. And I'm wondering if that's just my impression, or if I'm wrong, or if there's something to that.
Okay, thank you.
So in follow-up to Amélie's shameless plug, I'm going to put in another shameless plug for an article that Robyn mentioned at the outset that Greg and I and Amélie were co-authors on, that just came out a few weeks ago in The Lancet. There was a special series on Canada. And we have in that paper 2 maps, which in my view speak 1,000 words. And they came out of a conversation very early on where one of our co-authors said something along the lines of, in order to understand how difficult it is to deliver healthcare services in Canada, you just need to look at a map. And so we produced 2, and we have a little inset with a map of the UK, of England, as a comparator to help people, international readers, to understand what we're up against as a nation in terms of our sheer geography. And I think, so the short answer to your question is yes, of course, you're right, that in trying to deliver healthcare services across a vast geography, with many people living in relatively rural and remote areas, and an absence of distribution of healthcare workers to match that distribution of population, it is always going to be difficult and it is always going to be expensive. Having said that, we still spend less than most developed countries publicly on our healthcare system, so we could definitely afford to spend more publicly than we do. We're falling and falling actually on every OECD comparison in terms of what we spend publicly. So what I wouldn't What I wouldn't agree to, I guess, is the premise that Canadian healthcare is expensive because, of our geography. What I would say is it's complicated to deliver healthcare services across a vast geography by definition. Absolutely.
Did a study of circumpolar health systems from Russia, Nordic countries, Canada, Alaska. The most expensive health system in the world is Nunavut, and that is due almost entirely to medical transportation and healthcare, which is delivered in places like Ottawa, Edmonton, and Winnipeg. And that poses huge challenges for the government of Nunavut. It poses huge challenges for us generally. There are ways to address this. I think geography is important, and there are high-cost jurisdictions in this country beyond the territories. When you look at the provinces, and we did a calculation on this, and first is Newfoundland and Labrador, and that is because of the vast area of Labrador, but also the island of Newfoundland. Second is Saskatchewan. Third is Manitoba. They're very close. And there are ways of addressing that. You could have a calculation in the Canada Health Transfer, which at the margin adjusts for the higher costs of delivering services in these vast areas. But of course, that creates a bit of a zero-sum game, because if you have a static sum of money and at the margin you're calculating it, you're also taking away from some to pay for others. But it's a discussion that we need to have. It's certainly correct to say that countries with compact populations, large urban areas, it's much less costly to deliver health care.
Great. Okay, I want to thank our panel very much. I mean, it's been a fabulous both discussion and presentation, so thank you so much, everyone.